Welcome to Season 2, Episode 9 of the Home Healthcare Today show. I'm your host, Dr. Cleamon Moorer. It's May, and in the month of May, we have the opportunity to focus on National Nurses Month. Our guest on the show today is Dr. Randolph Rasch. Dr. Randolph Rasch is a professor and advisor to the Executive Vice President for Health Sciences at Michigan State University, and he is leading a university-wide effort to foster sustainable health, a pillar in the university's strategic plan in communities in the state of Michigan. Dr. Rasch has over 30 years of experience teaching in BSN, MSN, DNP, and PhD programs in nursing. He has published and presented in the areas of primary care, HIV risk reduction, and diversity in healthcare education and clinical practice. Prior to his current position, he was dean and professor of the MSU College of Nursing from 2015 to 2021. Previously, Dr. Rasch was chair of the Department of Community Practice Nursing in the School of Nursing at the University of North Carolina at Greensboro, and the director of two well-known family nurse practitioner programs, one for the Vanderbilt University School of Nursing, and the other was the School of Nursing at the University of North Carolina at Chapel Hill. Dr. Rasch was the first statewide Director of Nursing Services Program Director in the Tennessee Department of Correction, and he led development of the Quality Assurance Program for Health Services. Working with another Vanderbilt alum, Dr. Rasch co-designed and implemented a system of healthcare for the Tennessee Department of Correction that had not existed prior. He's a fellow in the American Association of Nurses Practitioners, a distinguished scholar and fellow in the National Academies of Practice, and a fellow in the American Academy of Nursing. Among his firsts are the first African-American male graduate of the nursing program at Andrews University located in Berrien Springs, Michigan. The first African-American male master's prepared family nurse practitioner. Dr. Rasch is a graduate of the FNP program at Vanderbilt University School of Nursing. The first African-American male to hold the PhD in nursing, and the first African-American male public health nurse in the state of Michigan. Among the many honors he has received are Distinguished Alumni Award from the University of Texas at Austin School of Nursing, the Lulu Wolf Hasenplug Award for Distinguished Career in Nursing from Vanderbilt University School of Nursing, the Dr. Jean Tranbarger Writing Award from the American Association for Men in Nursing. Dr. Rasch, welcome to our show.
Good to be here.
Yes, sir. Dr. Rasch, what an impressive background that you've had in academia, in public service, as well as the field of nursing at multiple institutions. Dr. Rasch, tell us about you. Tell us about you, growing up, your passion for nursing, students, and public service.
Well, I grew up in Michigan originally. I'm from Michigan originally, since we're on video, this part of the state,
Yes.
southwestern part of the state.
Uh-huh.
I grew up way out in the country, and I only went to religious schools all my life because I was raised as a Seventh-day Adventist.
Yes.
I went to a little one-room schoolhouse out in the country, and then Andrews University Academy and Andrews University. And I think growing up, probably I was interested in healthcare just because I had that background, and we were sort of inculcated with the idea that you serve.
Yes.
But I was also very much interested in art. So I could draw, I could paint, I could sculpt, and never been trained in any of that. And sort of quit doing it when I decided to become a nurse. I originally thought I would be a physician, but when I was in high school, our guidance counselor was a nurse, and he happened to be a nurse anesthetist. And I said to him, if I wanted to become a physician, but I became a nurse first, could I do that? And he said, yeah, you just have to get the prerequisites for medicine. So I went into nursing. And fortunately for me, at Andrews University, nursing started in your sophomore year. So I really didn't know that much about nursing. I just knew what most people probably know. And I started and I thought, well, I like this well enough. I'll stay with this. So it really turned out to be the best thing and probably more of what I wanted to do in healthcare than be what a physician typically does. And so that was exciting. You know, I think some years ago, maybe 10 or 15 years ago, my colleagues started saying to me, we didn't think you were ambitious, but we've learned who you are. And I said, first of all, why are we talking about my ambition?
Right, there you go.
But tell me what you're saying. And they said, you've been socialized to serve. And I hadn't thought about it before, but because of where I went to school, no matter what your major was, we were socialized to serve. It was religious school. We weren't socialized to proselytize.
Right.
We were socialized to serve.
Yes.
And so that has been a guiding thing for me in everything that I've done. I worked in the hospital. I liked working in the hospital, but I was 21 years old and it was night. I worked at nights, and I was like, okay, I've had enough of this. So one morning I went over to the health department and interviewed and drove the 30 so miles or so because I still lived at home, went to bed, and they called and talked to my mother, and she said, well, he's asleep, but I'll have him call you. So I called him and went into work, and then the next morning went into interview and they hired me. And it probably set the tone for the rest of my career. So one of the things I say about nursing, when we're doing what it is that we should be doing, then what physicians are doing and what nurses are doing are complementary, right? So we shouldn't be trying to replace each other.
No.
And what nurses do is we focus on who you are. Who are you as a person? And we don't try to change that. Whatever your health status is, whatever your medical care is, we try to work with you so it has as little impact on you as possible. Because if you radically change somebody's diet or exercise, they'll do it for a little bit, but they're not going to do it.
Right.
So I always said to students, you know, who knows what comfort food is? And they'd raise their hands, and I said, so when you're working with patients and there's a diet piece, find out what they eat and how can they eat that in a more healthy way because they're more likely to stick to it. If they need to exercise, don't make them think they need to go to a gym. If they're in the country, I remember one of our students who grew up in the country was working with families, and I said, what are you doing about the exercise? She was in the Army. And she said, I would talk to them and said, who are your neighbors and how far away are they? And they'd tell her, and she'd say, so we'll walk down to their house once a day and you've gotten that exercise in.
Absolutely.
So, you know, I think the passion for nursing is really to serve our fellow human beings in that way.
Yes.
So it's doing it as a nurse, which doesn't take anything from doing it as a physician or a social worker or any of that. The other thing I would say to students too is your ability to do the direct care with patients or work with the machines that are attached to patients. And then as I became a nurse practitioner, your ability to diagnose and prescribe are technical skills for a nurse. They allow you to be with a patient to do what a nurse would do. And nurses are educated and trained because that stuff takes training, but the education is how do you think about the people you're providing care for and how do you meet them where they are? And I'll just throw this in because right now, you know, there's a huge thing about DEI, diversity, equity, inclusion, health disparities and health,
social determinants,
all of that kind of stuff. When a nurse does what it is that a nurse should do, those don't become a problem.
No.
Because you begin to learn who this person is. That includes who they are culturally, all those things. And those aren't problems. Those become resources and richness for those patients. And if you pay attention, it becomes an enrichment for you as well. So I wanted to throw that out because if nurses do that, and it's helpful to learn all of that, but if you do what you're supposed to do, then you will learn that, and you will give the care that's appropriate to the person. The other thing I like to say about nursing is I would say to students two things. You'll always have a patient that is ticking you off.
Just a little, right?
And the thing that you do, I had a mantra, and I didn't realize other people had the mantra, but I learned it early, and it was to relax and think, it is not about you. And as soon as I did that, I could move along with patients. But the shocking thing was to have patients come back and request me. I didn't know that, but they would show up, and I'd go out and say, why are they here? Because we had a problem the last time. And they said, because they asked for you. So I learned that if you're real and authentic with people, they may not appreciate it in the moment, but it develops trust.
Yes.
And then you can move forward. And I'll tell you how important that is because I learned it in the prison system.
Yes.
So, they'd try to run a game on you. I mean, you'd catch them and say, okay, you are wasting my time.
Right.
And if you wanted to just come up here and talk, tell them that. And if I have the time, we can do that. But you're taking up time that somebody else could use.
Yes.
And those guys would laugh and go, oh, you caught me. But when they were seriously concerned, those of us who acted in that way, we were the ones they wanted to see. Absolutely. So we're covering a lot of things here.
Yes.
I just said that but those are, you asked me about the passion piece.
Yes.
And the passion piece is to be educated and trained in a way that you can provide, that you can serve your fellow human beings. In this case, you do it as a nurse.
Absolutely. Thank you, Dr. Rasch. Dr. Rasch, you have provided a lot of pearls in that opening response.
Scary, huh?
No, you really did. And I gleaned a lot of it. Being person-focused, person-centric for a nurse is a must-do or must-have. It seems to not only complement and aid those technical skills, but it gives the patient a sense of comfort, In view of you, Dr. Rasch, your background and what you just shared, you never stopped. From, being 21, working as a nurse at night, going back to school, being in the prison system, not as an inmate, but as let's clarify.
Although when you worked in there, sometimes you might have felt like that. But.
Absolutely, Dr. Rasch, as a caregiver, as a nurse, right? Dr. Rasch, what were some of those obstacles along the way? And then how did you overcome it? And then since it's National Nurses Month, how can we encourage other youth to pursue the field and to overcome some challenges?
It's interesting because when I get that question, it's always difficult for me to answer.
Yes.
So I was talking to my brother, and I tell people that I'm an introvert, and they go, yeah, right. On a Myers-Briggs, I rate as an introvert.
No.
But it's because Myers-Briggs is based on Jungian psychology. Mm-hmm. And Jung defined an introvert as someone who renews their energy by being alone. And an extrovert is renewed by being with people.
Right, the social.
So people confuse being gregarious with being an extrovert. True. So I'm gregarious, but it wears me out. Right?
Right.
But and now I'm forgetting what you asked me.
No, it's good.
But
yes.
But I think one of the things you do is you're talking about the barriers and obstacles.
Yes, sir.
And so the other thing I would say about that is that I'm naturally an optimistic person, and I naturally believe in my fellow human beings as well. And so it's hard for me to answer the question personally because I didn't see the obstacles. and I know they were probably there,
Yes.
but I didn't see them. But one of the things that happened to me is my friend Alexa Steifbergen is dean of the School of Nursing at the University of Texas at Austin. We graduated together, and she had me come do the commencement address. And all of the firsts that you mentioned, I've seen them written down and all of that, but I'd never heard anyone say them. And she introduced me and said all of that. And as she said it, something occurred to me that had not occurred to me before. So when I got up, I said to the students, well, you heard Dean Alexa say all these first. And I said, and as she was saying it, I realized I'd never heard anyone say it. And the thing that's important to know then is I was the first African-American male in all those places in school, but I was educated by white women. And what I appreciate, and it's something that we can all learn, is I realized looking back all these years at that time when I was telling the students, that's not how they saw me. They saw me as Randy. And I said, I can look back and see that I drove them crazy. And they would go, okay, let that one go. I remember, I wear a size 6.5 shoes, so I couldn't find white shoes. So I ended up getting navy shoes. And then I got sick of them. So I would wear them, but then I started wearing brown earth shoes. I remember going in one day in my uniform as a student wearing blue suede Spectators. They were dark blue, and they never said anything. But another thing that happened was one of the styles was back then, this would have been the 70s, because I was following GQ too. Sure. You'd wear a suit, and there was one time where you would wear a ski cap over, a knit ski cap. It was the style. You dress in a suit, whatever, and you wear a ski cap. So I decided to wear a white one.
Wow.
And so I got on the floor, and the nurses said, I don't know how I answered them, but I know I didn't lie. But they said, "Oh, you're wearing your nurse's cap," and I just sort of smiled and whatever. And so when the faculty member came down, she was standing beside me, and she said, "What's with the hat?" And one of the nurses said, "Well, isn't that his nurse's cap?" And she looked at the nurse and said, "The men don't wear caps. Take it off." So I took it off. But I look back at them, and so I give the example of they didn't only treat me that way. There were two other guys in the program. One was from China, one was from India. But whether we were men or women, they treated us as who we were. And so I can look back and see that there may have been barriers, but I didn't experience it that way. But having said that, once I left that cocoon, and in it, I could see how people were being treated in clinical and all those sorts of things. So, my advice to how you meet those obstacles, the very first thing is to know who you are. Know who you are, know what you're gifted to do. And then begin to learn from people how to deal with that. And sometimes it's how to actually say to somebody, this is how you're treating me. You may not realize it, but here's how it's affecting me. How can we move forward? But the other thing is to learn what the systems are like, what the systems do. One, to do the barriers, but what is built into the system that helps you overcome and deal with those things. And the other thing is, Wintley Phipps is a singer. My brother and sister-in-law know him pretty well, but he said to my sister, he said, "You need to learn my mantra." She goes, "Okay, Wintley, what's your mantra?" He goes, "Don't stay where you're tolerated, go where you're celebrated." If that's what it is, we train and socialize people to think, oh, stand up and be there and blah, 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 blah. No, get the H out. If you can't change it, and if you're being abused and all of that, don't stay. Learn from it and go someplace where they are welcoming you to do that. but let them know about it before you leave.
Great
Here's what you
advice.
did.
Mm-hmm.
Here's how it affected me. And don't tell me about DEI because you're just giving lip service to it. You're not really doing it.
Absolutely, Dr. Rasch. And Dr. Rasch, as I think about your journey and I think about those snippets there from Christian-based education, right? As a Seventh-day Adventist, and I think about rural background growing up, and then being a educator and dean in a state school, one of the biggest or largest universities in the country, Michigan State. I can't help but think about all those students out there, right? And as they think about career trajectories and what the 21st century or mid 21st century has to offer them, how vital do you believe, in all the various tracks that students can take from a number of different backgrounds, whether it's rural or urban or, faith-based backgrounds, how important will health careers be in the mid 21st century?
Well, they continue to be extremely important.
Yes.
So I'm a Trekker, and I also like Star Wars.
Okay.
But if you look at Star Trek from the 60s, and I didn't look, when it was on, I didn't see it, but when I was in the PhD program it was running, I would go home from class and I would turn it on and watch it.
Mm-hmm.
But one of the things that you remember in there was sick bay.
Yes.
So there's all of that there. You think it's because of what health means, and it's bigger than just the absence of disease. It's wellness, all of that kind of thing. It's you mentioned the social determinants of health, finances, all those things affect our health. And we especially know it in minority communities, but it's in other communities too. Wealth can be a social determinant of health, and we look at it in a positive way, but it's not always as protective as you think. So health is always going to be something that we're living with. If you look at Star Trek, and the thing that I think nurses need to think about, and it's something we need to think about in education, it's always going to be important. How we do it is going to change. But the rule of thumb, the thing I always said, that I said before, is we are here to serve our fellow human beings. But we're also here to be scholars in serving our fellow human beings. So that's the importance of education. How do you think, not just how you train? When you focus on training, those things that you train people to do may last for a year. And if it changes, how do you, so you're looking at technical skill.
Yes.
Technical skills aren't difficult to learn, but how you learn to think about your fellow human beings, how do you learn to care for them is going to be the rule of thumb. And then how do you continue to learn? So the future is here. So I brought up Star Trek because the National Institutes of Health is a place that we do research to look at what is the cutting edge thing that we need to do for care for human beings. And more recently, in the last few years, we've had, I'm so proud of this, nursing scholars who are at NIH doing research that infuses nursing. One of the ones is looking at closed head injuries with athletes, and she's doing stuff that's technical that you think is medical and all of that, but she's also using it to say, and how do not only other health professionals use this information, but how do nurses? I bring it up because if you look at Star Trek and they're traveling where no one's been before, and the mission and all of that. So they're always exposed to different illnesses and things. And what you see in sick bay is a mini NIH. And what you see is the physician and the nurse having access to all kinds of information and thinking about it in these ways, because they can't wait for NIH to do something. They have to solve it then. And if you watch those shows that focus on that, the solution comes from looking at all that then, thinking about it, and coming up with something to deal with it right then. And then they can share that information. So I think this is important because nurses tend to bow at the idol of research. And then we say stupid things like the PhDs develop knowledge and the clinicians apply it. Well, who says that? We need to get over it. So a clinical scholar, a scholar learns the information. I'll give you two examples. So how do clinical scholars do this, right?
Right.
But the process is all the same. And the process is looking for patterns.
Yes.
So if you only learn to look at this patient and then this patient and this patient and don't see that there are patterns,
Yes.
then you don't develop that knowledge. So a very concrete example, I hate giving it because
okay.
it's drugs,
Please do.
but it's a concrete example. Off-label uses of drugs come from that. So there was a drug, Wellbutrin, which was for depression,
Yes.
and now it's also Zyban, which is for smoking cessation. Nurses should have figured this out if we're looking at it and paying attention. So what happens is someone's depressed and you prescribe Wellbutrin for them, right? Not true of all depressed people, but a lot of times some of them may be smoking a lot.
Yes.
The clinicians notice, wait a minute, these people aren't smoking as much. And as they put it together, the only thing that made sense was the Wellbutrin. So they started prescribing Wellbutrin for smoking cessation, right? And it worked. It's an off-label use of drugs. The reason it's called Zyban for smoking cessation is that the health insurance companies, if you were prescribed Wellbutrin, said they're really depressed and you're treating for depression, but you're not putting the diagnosis because it makes your premium go up.
Yes.
So it was worth it to the company to do the clinical trials for smoking cessation, and that's why it says Zyban.
Gotcha.
So I give it to say what it means is that the way you develop knowledge is you look at patterns.
Yes.
And if you're a clinician, you're looking at these patterns and you go, what do those mean?
Yes.
If you're a scientist, you do it the same thing. You're looking at patterns, but you're gathering data, right? If it's a lot of data from a lot of different people, the way you analyze it is through statistics.
Yes.
If it's qualitative, you do it the way the clinician does it. You go, what are these themes? What do those mean? What is it? So we need to give clinicians that piece. So I'll give you one example from nursing. I remember reading it, but I can't find the reference, so now I say it may be apocryphal. But years ago, when they first started neonatal care for premature infants, the perspective, the approach was to look at the gestational age. When would this child have been born? And so the care was based on, they did certain care, and when they would have been the time they would have been full term, they progressed the care. And this was happening, and the nurse was progressing the diets. And she progressed the diet on this one baby, I think it was a boy, and this little red flag went up. It doesn't have to be a little red flag, but it has to catch your attention. But the little red flag went up, and she didn't think anything about it. But that baby started going bad. I think he made it, but he started going back. Well, she remembered that. And she pulled his chart and looked at what his condition was before his diet was progressed and after. And so she noticed that it changed. So then what she did was proactively, as a clinician, started making observations. So she started looking at all the babies to see what happened. And what she found was it didn't happen to all of them, but there was a significant number of them that their condition changed. And then she did what nurses always do, because we haven't educated them to be able to do it themselves. She told it to a physician who figured out two things that nurses should have known already. The first thing is, remember, we care for individuals. So don't have a uniform approach to everybody. Pay attention what this is. But what the physician also figured out is you pay attention to growth and development of each one, and that's how you do it. So you go to a shoe store. This is from a book of logic that I used in my dissertation. You go to a shoe store and you buy a pair of shoes. You get great wear out of them. You go back to that shoe store. You get great wear out of those. Those are reasoning from analogy. It can be, well, I got great wear because I bought them from this shoe store. Or maybe I got great wear because every time I bought them, I bought Bass Weegens.
Right.
So there's a way of thinking about it, but then you can test it. Once you do that, you can test it, and that's the deductive testing. Those are important things that we need clinicians to learn. So as, a long way to answer your question, but as healthcare transitions and becomes more technical
Yes.
or all of these things that we have, it doesn't remove the clinician's ability or the human being's ability to think like a scientist, think like a clinician who's developing knowledge.
Wonderful, Dr. Rasch. Dr. Rasch, Dr. Rasch, you mentioned in your response several key points. One of which really will stand out, I believe, to a lot of our listeners as well as viewers of the show. You mentioned that perhaps in terms of social determinants of health and economics to an extent, or wealth, perhaps there are some negative consequences, whereas a lot of our young people out there that are considering a career field will certainly think about money and think about money a lot in their pursuit. Do you mind just elaborating
Talking about money?
Well, yes, but what perhaps could be some negatives in terms of...
Well, let me talk about money in two ways.
Okay.
One
Yes.
is nurses tend to want to give it away.
Uh-huh.
I loved years ago that every board of nursing defined nursing as doing it for pay.
Yes.
It is a career. You should be compensated for it.
Yes.
And you should be fairly compensated for it, and often that doesn't happen.
Yes.
So I just wanted to mention that.
Yes.
You're highly educated and skilled and trained. You should be paid for those services.
Yes.
Yes, you should be serving your fellow human being, but they're coming to you because you're a professional, and we pay professionals for what you do. Now, to talk about social determinants of health. Excuse me, let me.
Sure. Absolutely.
So one of the things that nurses emphasize frequently is caring for people who are disadvantaged and all of those kinds of things.
Yes.
And it's particularly true for nurse practitioners. And part of that is because nurse practitioners came out of public health. It was public health nurses who became pediatric nurse practitioners. And the patients that you see in public health tend to be the disadvantaged and the underserved.
True.
You don't see the trouble going on in the others because nothing refers them to you.
Yes.
So one of the richness of the experience I had as a public health nurse in Benton Harbor, and you'll really appreciate this. I was a public health nurse, but the health department was a combined agency. So it also provided home health,
Yes.
and the people who provided the home health were the public health nurses. So my caseload was mixed. There were 8 of us,
Yes.
4 for Benton Harbor, 4 for the rest of the county.
Yes.
That tells you what was going on in Benton Harbor. So we not only saw normal, regular public health patients, we had home health patients. And so one of the things you realize is human beings are human beings, no matter if they have the money or if they don't.
Yes.
And I hear wealthy people say this, mostly Oprah Winfrey and people she's had on. They go, we put our clothes on the same way. We have bathrooms, we have closets, we may have more clothes and all of that, but it's still the same thing. And so when you're a nurse and you're looking at patterns, if you're looking at a family, you're looking at things, and it's the red flag. When I used to teach students about assessing families, I said, so you look at how families are grouped. There may be 5, but there may be a dyad, a triad, or whatever. The first thing you want to know is, why is there a subset, dyad, or triad? And they're going, are you saying it's a relationship that's not appropriate? I said, no. I'm just saying that's how human beings work.
Yeah.
But when you see it, pay attention, because you might see other things that say,
Yes.
I'm concerned about this. So when I was at Benton Harbor, one of the things we learned with protective service, there was a big thing for all of us to learn about child abuse,
Yes.
right? Well, you learn to see these patterns, and they happen in all kinds of homes.
Yes.
It's just that the wealthy have the ability to disguise it because nobody's coming into their homes to see anything. And I say it as it's important to see all those things because there's something that you can do. I remember when I was learning this, and it's been a while since I looked at it, so I don't know if they're still approaching it in the same way, but I think they do. What we knew, and I worked closely with protective services, we were always in court testifying in child abuse and sometimes adult cases. But one of the primary goals of treatment in child abuse or adult abuse, and the thing that's really difficult is if there's sexual abuse.
Yes.
Guess what one of the primary goals of treatment and care was? To put the family back intact, which really made it difficult for people to think about that.
Yes.
So the perpetrator has to be identified, has to be punished for it, has to recognize it and apologize, because what happens to the child is they take the blame. But even if nobody says it, this happened. This person who's a part of our family, whether it's in the house or outside of the house, is all of a sudden, this is happening because I said something. Maya Angelou talks about this. She talks about being raped in her, when she was in St. Louis, and the perpetrator was the boyfriend of her mother, I think. And she talks about how he was arrested and released and then found dead. And the police said he had been kicked to death. And she then took the blame. She thought it was her responsibility, and if you've heard her, she stopped talking for years because she said, I realized that my voice was so powerful that it might kill somebody. This is the kind of stuff we deal with.
Absolutely.
And it's important for people to be punished. But it's also important to try to whatever. So remember, I worked in the prison. Most people don't realize that most inmates, I don't know what's going on now because the sentencing stuff has become kind of crazy, but most inmates are going to be released. And so if they're treated badly within the prison, when they're released, they take that with them. And if there's an effort to rehabilitate them and to get them to some normal way of thinking, you might have somebody who's going to be successful once they get out. And even if they're not going to get out, the prison is a community. It's like a little town. So it's still going to be important for that. Absolutely. I know I've wandered away here.
This is good, Dr. Rasch. I'll tie it together to our next question prior to our commercial break here. Dr. Rasch, the way that you've just explained a very complex issue in terms of the importance of nurses in the future. You brought the future current. You talked not only about economics, but you really honed in on some of those psychological and mental health challenges with abuse. I mean, you even went in terms of trauma, right? And cited, Maya Angelou's book and her story and testimony. Nurses are very important in so many different ways, and it's not always explained the way that you've explained it in so many different areas. Prior to our commercial, Dr. Rasch, what are we going to do about this nursing shortage?
Well, I think there are a couple of things that I think we have to work on. One is, where do nurses work? So I think one of the things you've seen is, and this should have been, I mentioned money before. So everybody talks about how nurses are leaving hospitals. They're being hired by travel nurses.
True.
They're paying them a lot of money. And the question is, why weren't they being compensated for what they were doing before? So that's one piece. The other piece is, how are nurses treated where they're in the hospital or where they're in anyway? So sometimes the situation where they are, they take, I'm going to say abuse or disrespect or whatever, and it's not just from other healthcare providers. Sometimes it's from other nurses. And so the issue is, how do you make, most nurses love nursing. And when I was growing up, if you didn't like what was happening in a certain hospital, you left and went to one where you liked that.
Yes.
What's happening now is nurses, young nurses, aren't looking for the better place to go work. They're leaving the profession and going into other professions. So we're losing people we shouldn't be losing.
True.
And part of that is how we're paying them, and part of that is how we treat them. I'm also licensed in North Carolina, and the Board of Nursing in North Carolina has this tremendous just culture piece, because the board has recognized there that we're losing nurses, and so they're doing things to support nurses who, once they're out, but they're also trying to do it with student nurses.
Yes.
How do you speak up for yourself? How do you get the allies and the things that you need to care for this? So, two things is we're losing people we should not be losing because we're not paying them and we're not looking at the conditions under which they work. There is no excuse for that.
No.
So that's one. The other piece is that we don't have the faculty. If you look at a lot of programs, we can't admit the number of people that we could admit. And right now in the pandemic, what I saw is so many people are interested in nursing because they're hearing nurses talk and go, oh, I didn't know that's what nursing is, because they thought the bedpan and all of that, but it's like, they're smart, they have to think, and they're talking about this. So we've had so many people. I remember we're looking at admissions, people who were the applications for people who had not been nurses had doubled. I can't remember this, but the percentage was really high. And we also had people who had other degrees and careers coming back for the second degree in nursing because they were like, this is something I kind of wanted to do, but I didn't really know. So we have to do a couple of things. One, deal with those conditions that drive nurses out of nursing. That's the pay and what they experience when they get there. So that's one. And the other is leverage our ability to educate. And there are a couple of things there. We are educating in the old way. So with all of the new technology and all of those things, there are things that we can do, especially on the technical things that you can learn. But educate nurses to think, educate them to, and we do it, but we can begin to do it in a way that is more effective and more efficient. I always just talked about the 3 E's. Effective, efficient, and entrepreneurial. And
nice.
that is, faculty have to rethink how they think and how we educate. I've been doing it a long time. There are a lot of faculty, not a lot, but there are faculty who, if you look at the assignments, it's busy work. And I used to say to the faculty that reported to me, it's busy work, why are you having them do that? And if they demonstrated it a couple times and they've got the competencies, how many times are they gonna have to do that? Stop. If it's busy work for the student, it's busy work for you, because every time they do it, you have to grade it.
Absolutely.
So we have to think differently about this. And this is not only in education. The other thing I didn't mention in practice is, so I have colleagues now who are chief nursing officers who are rethinking it, and they go, we have to rethink what we do in nursing. So we're asking nurses to provide care that we probably can't afford for them to provide. And I was talking about this with some folks from a major consulting firm. They consult with hospitals and all of that, and they said, you're doing something with nursing. I said, well, we're doing this, and they said, yeah, but you need to quit. And they said, so the high touch piece can be done by people who are not nurses.
True.
Nurses need to know how to do the high touch, but they have to be thinking, when do I do this? But also to be supervising people so that they're doing it and doing it in an effective way. When you decide to do it, it isn't just to go do this. Sometimes it's just to spend time with the patient.
Absolutely.
And the way you spend time with patient is to give a bed bath and to do this, but you don't always have to do it, so that you know when you're going to do this so that you can spend time with them to get to know who they are, to adjust care or develop care with them that's appropriate. So I think there are a lot of things that we could be doing. We still need nurses,
Yes.
but we may need to rethink how we employ nurses.
Yes.
And rethink what we're doing. And it's already coming from our colleagues in practice about how they're putting nurses to work. And we have to be thinking about it in terms of how we educate nurses too.
Brilliant response, Dr. Rasch. We'll go to a commercial, and when we get back, we'll talk about some of those fields, like some of those home health aides and certified nursing assistants that could be of great aid to patients as well as nurses.
Yep.
We'll be right back.
Spring is a beautiful time in Detroit and Southeast Michigan. American Advantage Home Care brings that energy, joy, and vitality of the season right into your home, coupled with skilled home health care services. A world-class team of clinicians can help you to thrive, maintain, and rebound in the comfort of your own home. Finding a home health care agency more compassionate and caring than American Advantage Home Care is a long shot.
Welcome back to Season 2, Episode 9 of the Home Health Care Today show. It is National Nurses Month. And yes, we have the pleasure of speaking today with Dr. Rasch.